So what I want to do is give an overview of chronic kidney disease and some of the complications of chronic kidney disease. So the things I want to discuss this morning include the staging of chronic kidney disease, how to assess the glomerular filtration rate. Then we'll switch and talk about blood pressure control and the optimal use of blockade of the renin-angiotensin system, specifically how to deal with the complication of hyperkalemia. And then we'll talk about anemia management and some of the new things in terms of anemia management. And then finally, we'll end with metabolic bone disease. So first, we're going to talk about staging and the glomerular filtration rate. So the definition of chronic kidney disease as promulgated by the National Kidney Foundation is kidney damage for greater than or equal to 3 months, defined by structural or functional abnormalities of the kidney, with or without a decrease in the GFR. And these may be manifested by either pathological abnormalities or markers of kidney damage, and these might include abnormalities in composition of blood tests or the urine, or abnormalities in imaging. It's also defined by the GFR, a GFR that's less than 60 mLs per minute per 1.73 meters squared for greater than 3 months with or without long-term kidney damage. We can divide kidney disease into stages based upon the glomerular filtration rate. So stage 1 is defined as kidney damage with a normal glomerular filtration rate greater than or equal to 90. Stage 2, a mild decrease in the GFR, 60 to 89. Stage 3, a moderate decrease in GFR, 30 to 59. Stage 4, a severe decrease, GFR of 15 to 29. And stage 5 is the stage at which patients are either on dialysis or being close to initiation of dialysis with a GFR of 15 or less. Now, the staging system is also useful because there are certain benchmarks and guidelines that we can follow based upon the stage at which the patient presents. So stage 1 is where you'll really be thinking about the diagnosis and treatment of comorbidities, slowing progression, and importantly, cardiovascular disease risk reduction, because what really is the major killer of patients with chronic kidney disease is cardiovascular disease. Stage 2, we're thinking about estimating progression. How likely is this person to progress to end stage? Stage 3, evaluating and treating complications. Stage 4 is very important. That's the stage of preparing the patient for renal replacement therapy. So this includes not only placement of a vascular access, but importantly, psychological preparation for renal replacement therapy. And that's where partnerships with the primary care providers and the interns becomes very key. And stage 5 is the stage at which patients are actually on renal replacement therapy. The staging system is also useful because there are certain metabolic consequences that occur at varying stages of chronic kidney disease. So for example, stage 2 is where you might begin to see an increase in the PTH. Stage 3 is where you may see decreases in calcium, anemia, malnutrition less commonly than we used to see. Stage 4, hyperphosphatemia, metabolic acidosis, and hyperkalemia become more common. And stage 5 is where the clinical syndrome of uremia typically becomes apparent. So now let's turn to think about how do we actually estimate the glomerular filtration rate. Since it's so important in our defining the stage of chronic kidney disease, how do we actually get there? Well, you all know that serum creatinine in and of itself is a poor predictor of the glomerular filtration rate. So a thin elderly woman with a creatinine of 2, at face value it might not seem that high, but based upon muscle mass, that creatinine of 2 may actually represent significant chronic kidney disease. And you all know that the ideal substance for measuring the GFR is something that is freely filtered at the glomerulus, but is neither secreted nor reabsorbed. And in research studies, clearance of iothalamate is considered often the gold standard for the measurement of the glomerular filtration rate. So creatinine is one of those substances that we use commonly for estimating glomerular filtration rate. Why creatinine? Because creatinine is freely filtered at the level of the glomerulus, but it's not reabsorbed. However, the caveat is that 10 to 40% of urinary creatinine is derived from creatinine secretion in the proximal tubule, and this creatinine secretion can be affected by medications. So 2 medications as examples that may affect creatinine secretion include trimethoprim, which is one of the components of Bactrim, and cimetidine. One can calculate the creatinine clearance from a 24-hour urine collection. You need the urine creatinine, you need the urine volume, you need the serum creatinine, and you need to know that there are 1,440 minutes in a day. So here's an example how one would calculate creatinine clearance. So from a 24-hour urine, we know that the urine volume is 2 liters. As urine creatinine is 88 milligrams per deciliter, the serum creatinine is 1.1. You plug it into the equation, and it comes out with a creatinine clearance of 111 mLs per minute. The caveat is that the creatinine excretion per day must be adequate. In men, about 20 to 25 milligrams per kilogram of lean body weight, and in women, 15 to 20 milligrams per kilogram. Now, there are other ways that one can estimate the GFR. The Cockroft-Gault equation was commonly used for many years. It uses the age, the weight, and the serum creatinine as a correction factor for women. So Cockroft-Gault equation has been used. But what is more commonly used now is the MDRD equation. The simplified MDRD equation takes into account the serum creatinine, age, sex, and race. The caveat to the MDRD equation is that it is only validated for patients with established chronic kidney disease. And this is the equation from which the automated eGFR estimates are derived. So one of the questions that often comes up is, what do you do with a muscular young man who has a creatinine of 1.4? Because if you plug the numbers into the MDRD equation, it may give you a false estimate that the patient has actually chronic kidney disease. So for example, if you take the 40-year-old white man, and remember with the urine volume and the urine creatinine that I gave you, that his creatinine clearance was 111 ml per minute, whereas by the MDRD equation, his GFR is 79, and by the Cockroft-Gault equation, the GFR is about 88 mLs per minute. So there are a few pitfalls of the eGFR based upon the MDRD equation. One is that the lower the serum creatinine, the less accurate the MDRD equation is at estimating the glomerular filtration rate. So in those cases, a 24-hour urine for creatinine clearance may be a better way of estimating the glomerular filtration rate than the MDRD equation. So an elderly patient with a creatinine of 1.1 may have a completely normal GFR, but remember that by the MDRD equation, it may underestimate that patient's GFR. Now, there are some newer equations that are being developed. For those of you who saw the July 5th issue of the New England Journal of Medicine, there was a nice paper describing the use of cystatin C combined with creatinine as a better way of estimating GFR. So we may see newer equations and newer tools that are less imprecise at the lower end of the serum creatinine coming online as ways of estimating the glomerular filtration rate. So let's move on and talk about blood pressure control in chronic kidney disease, and we'll focus specifically on the optimal use of ACE inhibitors and angiotensin receptor blockers. So blood pressure control is important for a number of reasons. We know that blood pressure control is important in terms of retarding the progression of chronic kidney disease. It's important in reducing cardiovascular risk. And our recommended targets currently by both K-DOQI and JNC7 is 130/80. Now, based upon some of the newer trials, have not shown as robust a benefit with this degree of blood pressure control. It's not clear whether this recommendation will hold, so we'll have to see what the next iteration of the Joint National Committee's recommendations are. So what are the indications for ACE inhibitors and ARBs? Well, we know we have very good evidence for diabetic kidney disease, both type 1 and type 2, that blockade of the RAS system is important. We know that in a variety of proteinuric kidney diseases, blockade of the renin-angiotensin system is important. We know from the ASK study that blockade of the RAS system is important for hypertensive nephrosclerosis. And we know that in microalbuminuria, a blockade of the RAS system is important. One of the common questions that comes up from internists and primary care providers is the following. Is there a GFR below which there is no benefit of starting the patient on an ACE inhibitor or an ARB? So commonly, you guys will see, and we'll see patients who have a GFR of 20, creatinine of 4 or 5, and the question is, should we really try to put that patient on an ACE inhibitor or an ARB? Well, this is the best paper that I found that has tried to examine this question. This paper was published in the New England Journal in 2006. This is from China, and they took patients with established chronic kidney disease and divided them into two groups based upon the serum creatinine. So all these patients had proteinuria and varying degrees of chronic kidney disease. The patients in group 1 had lower serum creatinines, I believe about 3 or less, and the patients in group 2 had more severe chronic kidney disease with creatinines greater than about 3 or so. And they felt that it was important that all the patients with the lower serum creatinines and proteinuria be placed on an ACE inhibitor. However, for the patients with more advanced chronic kidney disease, the body of evidence was not as good as to whether those patients should be placed on an ACE inhibitor. So they randomized the patients in group 2 to either benazepril or placebo. And you can see that even with the patients with chronic kidney disease that was more advanced, the patients who were placed on benazepril were less likely to reach the primary endpoint, which I believe was doubling of the serum creatinine, or reaching the endpoint of dialysis. So in patients with proteinuria kidney disease, even more advanced chronic kidney disease, perhaps one should try to maintain those patients on blockade of the renin-angiotensin system. Now, of course, the more advanced the chronic kidney disease, the more likely the patient is to develop hyperkalemia as a complication of treatment with RAS blockade. So one has to think about, what are the risk factors for development of severe hyperkalemia? And this is what I call the hyperkalemia perfect storm. A patient who is on an ACE inhibitor or an ARB, has pre-existing chronic kidney disease, comes in volume depleted, taking some NSAIDs, and throwing some Bactrim for good measure. So risk factors for hyperkalemia and the use of drugs that interfere with the renin-angiotensin system, as we mentioned, chronic kidney disease in and of itself, diabetes, decompensated congestive heart failure, volume depletion, older age, concurrent use of drugs that interfere in renal potassium excretion, nonsteroidals, beta blockers, calcineurin inhibitors, heparin. For those of you who don't remember, heparin can block aldosterone release at the level of the adrenal gland, ketoconazole, potassium-sparing diuretics. These include spironolactone, eplerenone, amiloride, triamterene, trimethoprim. Trimethoprim, which is one of the components of Bactrim, acts just like a potassium-sparing diuretic, pentamidine, and then finally potassium supplements, including salt substitutes. So we're always talking to our patients about low salt diets, and if they pick up some of the salt substitutes from their favorite grocery store, it may substitute potassium chloride for sodium chloride. So this is from a nice review by Biff Palmer, just demonstrating at the tubular level how some of these drugs may act to cause hyperkalemia. So if you focus in on this portion of the slide, you'll see that within the cortical collecting tubule, there is a sodium channel, the epithelial sodium channel, and this epithelial sodium channel leads to the uptake of sodium from the lumen. This creates a lumen negative gradient that drives potassium secretion in this way. And drugs like amiloride, triamterene, and trimethoprim block this sodium channel. When you block this sodium channel, you destroy this lumen negative gradient that drives potassium secretion. So similarly, when you're volume depleted, there's less urine flow rate and therefore less potassium secretion going in that direction. Aldosterone acts by increasing the number of these channels and increasing this channel's open probability. So aldosterone acts somewhat indirectly, and you may block this with spironolactone or eplerenone. Importantly, I mentioned to you that trimethoprim acts as a sodium channel blocker in the cortical collecting tubule. So this was a nice review that was published in the Archives of Internal Medicine, just showing that for patients who came into the hospital with hyperkalemia, there was a high likelihood that these patients had been on recent antibiotic therapy, and if you look specifically at Bactrim, the odds ratio was about 6.7 for development of hyperkalemia. So the use of Bactrim is a major risk factor, particularly in the elderly, for the development of hyperkalemia associated with these drugs. So how does one treat hyperkalemia? Well, first, dietary potassium restriction. It's very important to get patients in to see a dietitian for counseling regarding a low potassium diet. Treat the metabolic acidosis that may be associated with a type 4 renal tubular acidosis. Use loop diuretics. And then only as a last resort, if one follows these 3 steps, will you need to use K-oxalate or sodium polystyrene sulfonate for the treatment of chronic hyperkalemia. Now, not to get too tubular on you, but this is just to remind you of how loop diuretics act. They act in the thick ascending limb of the nephron. They block the furosemide-sensitive cotransporter, which moves both sodium and potassium in this direction, and induces the loss of both sodium and potassium. Okay, so we're going to switch gears now and move to the third portion of the talk, which is going to focus on anemia in chronic kidney disease as one of the complications. So remember that I said that anemia typically becomes apparent usually at about stage 3 of chronic kidney disease to stage 4. However, there's been a major paradigm shift over the last 10 years or so in our understanding of how one deals with the anemia of chronic kidney disease. I'm going to try to highlight some of that. And much of this work has been done by my colleague, Dr. Ajay Singh. So the pathophysiology of the anemia of chronic kidney disease, as you know, there's decreased production of erythropoietin. So erythropoietin is produced by the healthy kidney, and the diseased kidney produces less of this hormone. There may be direct marrow suppression by uremic toxins. There may be shortened red blood cell survival, increased blood loss, particularly in patients on dialysis, iron and folate deficiency. There's a block in iron absorption in patients with chronic kidney disease. And finally, there may be resistance to erythropoietin. Many of these patients are chronically inflamed, and inflammation leads to resistance to the effects of erythropoietin. So why do we try to treat the anemia of chronic kidney disease? Well, there are a number of proposed benefits. There's improved in functional status and sense of well-being. What we used to think were uremic symptoms may actually have been symptoms of anemia. So we're finding that we can start patients later on dialysis if we actually deal with the anemia. There's some evidence that may reduce macular edema in diabetics, maybe some benefits in terms of increasing cognitive function, reductions in left ventricular mass, and then many patients with chronic kidney disease and patients on dialysis have impaired or abnormal sleep patterns, and correcting their anemia may have some salutary effect. So, as I said, many of these patients are iron deficient. So one of the first steps is to deal with the iron deficiency. We'll try to maintain the iron saturation somewhere between about 20 and 50%. We'll try to maintain the ferritin between 100 and 800 nanograms per ml. And we're fairly generous with the use of intravenous iron. Intravenous iron comes in a number of preparations that are available in the United States. Iron sucrose is available as Vinifer. Ferric gluconate is available as Ferlecit. The new kid on the block is a preparation called ferromoxetol, which is sold under the brand name Ferraheme. There still is an older preparation of iron dextran, which is sold under the trade name Infed. However, Infed use has declined significantly because of the rate of severe allergic reactions, including about a 1.7% risk of anaphylactoid reactions. So patients who are anemic and are iron replete may need an erythropoiesis stimulating agent. The agents that are available in the United States include Procrit and Epogen. Procrit for patients with chronic kidney disease not on dialysis, and Epogen for patients who are on dialysis. And darbepoetin or Aranesp are the preparations that are generally available. Darbepoetin has a longer half-life and requires less frequent administration. The ESPs are generally given subcutaneously in pre-dialysis patients and intravenously or subcutaneously to dialysis patients. Up until about a year and a half or so ago, I would always say that it was given intravenously to dialysis patients. However, in January of 2011, we moved into a bundled environment in which dialysis units are paid one flat rate for the whole dialysis treatment, including erythropoietin. One can generally use a little bit less erythropoietin when it's given subcutaneously than intravenously. Therefore, many dialysis units have moved to the administration of erythropoietin subcutaneously so they can use less and be more cost efficient. So the FDA label for the use of Procrit in 2007 warned of increased mortality, serious cardiovascular events, thromboembolic events, stroke, and increased risk of tumor progression or recurrence with the use of this drug. In chronic renal failure, the FDA label said in clinical studies, patients experience greater risks for death, serious cardiovascular events, and stroke when administered ESAs target hemoglobin levels of 13 grams per deciliter and above. One should individualize dosing to achieve and maintain hemoglobin levels within the range of 10 to 12 grams per deciliter. About a year or so ago, the FDA changed the label, and for CKD patients not on dialysis, the FDA advised to consider initiating ESA treatment only when the hemoglobin level is less than 10, and the following considerations apply. The rate of hemoglobin decline indicates the likelihood of requiring a blood transfusion and reducing the risk of alloimmunization and/or other red blood cell transfusion-related risks is a goal. And if the hemoglobin level exceeds 10, reduce or interrupt the dose of ESA and use the lowest dose of ESA sufficient to reduce the need for red blood cell transfusions. For patients on dialysis, the FDA recommends the following. Initiate ESA treatment when the hemoglobin level is less than 10. If the hemoglobin level approaches or exceeds 11, reduce or interrupt the dose of ESA. When initiating or adjusting therapy, monitor the hemoglobin levels at least weekly until stable, then monitor at least monthly. For patients who did not respond adequately over a 12-week escalation period, increasing the ESA dose further is unlikely to improve response and may increase risks. So this change in the label has really changed the way in which most of us approach the treatment of anemia in patients with chronic kidney disease. So initiating the ESAs at a lower hemoglobin level, we're being much more judicious about escalating the dose, because remember that many of these patients who are not responding are inflamed and are only going to respond to particularly high doses, and it's those high doses of ESAs that may confer the additional high cardiovascular risk. So the final complication I want to talk about, chronic kidney disease, metabolic bone disease. This is what we used to call renal osteodystrophy. The new nomenclature is that we call it CKD-MBD, which stands for chronic kidney disease, metabolic bone disease. Now, the pathophysiology of renal bone disease is that as the GFR declines, one gets reductions in the levels of calcitriol, or 1,25-dihydroxyvitamin D3. Phosphate clearance declines, and as phosphate clearance declines, phosphate levels rise. And in response to this increase in serum phosphorus and a reduction in levels of calcitriol, calcium levels also fall. This feeds back on the parathyroid gland so that PTH levels rise. This reduction in levels of 1,25-dihydroxy-D3 and hypocalcemia may lead to osteomalacia. At the same time, the increase in the PTH leads to secondary hyperparathyroidism. So all these things together lead to the syndrome of renal osteodystrophy, or as we now call it, CKD-MBD. So how does one manage bone disease in patients with chronic kidney disease? Well, probably one of the first steps is dietary phosphate restriction. We know from animal studies, for example, that if you restrict the amount of phosphorus in a dog's diet, PTH will normalize. It's very hard to restrict phosphate levels in the human diet to that extent, so we use phosphate binders. So phosphate binders are drugs that are given with meals to increase the absorption of phosphorus from the stomach and the gastrointestinal tract, so the phosphorus is excreted through the gut. The ones that are commonly used include calcium carbonate, plain old Tums or generic calcium carbonate, calcium acetate, which is sold under the brand name Foslo, sevelamer. Sevelamer is a non-calcium-based binder that's sold under the brand name Renagel, or now there's a second preparation that's sevelamer carbonate that's sold under the brand name Renvela. The new kid on the block is lanthanum carbonate, which is sold under the brand name Fosrenol. So as I told you, the levels of calcitriol fall, and so one can give calcitriol in the form of 1,25-dihydroxyvitamin D3 back to patients to reduce the level of PTH. And the ones that are commonly used include calcitriol or rocaltrol, paracalcitol or Zemplar, and doxorcalciferol or Hectorol. For patients who don't respond to either of those drugs, one can use the direct inhibitor of the calcium sensing receptor, cinacalcet, which is sold under the brand name Sensipar. The major difference between this drug and these three is that this one is much more expensive than either of these drugs. And then finally, for patients who don't respond to any of the medications, parathyroidectomy may be necessary. So the K-DOQI guidelines give us suggested targets for PTH in patients with chronic kidney disease. So one doesn't want to normalize the PTH in patients with chronic kidney disease. If we completely normalize the PTH, we tend to give the patients a different form of renal osteodystrophy called low turnover or adynamic bone disease. So patients with chronic kidney disease need a slightly abnormal PTH to give it somewhat of an engine for bone turnover. So our targets for PTH in patients with CKD stage 3 are that is a GFR of 30 to 59, is a PTH of 35 to 70. For patients with a GFR 15 to 29 or stage 4, 70 to 110. And for patients with stage 5 CKD or on dialysis, 150 to 300. Now, I don't obsess over these numbers very much because particularly for these two categories, this is completely opinion-based. So these are general rough guidelines, but I think we have more evidence for the patients on dialysis in terms of what our target PTH is. And there will be newer guidelines that are being put together by K-DOQI, which is sort of a worldwide organization that's promoting guidelines for management of patients with a variety of complications of CKD. Vitamin D deficiency, that is nutritional vitamin D deficiency, is common in patients with chronic kidney disease. And correcting this vitamin D deficiency of 25 hydroxyvitamin D may be important in lowering the PTH in patients with hyperparathyroidism. So what we try to do is control the serum phosphorus with both diet and phosphate binders. We'll measure the intact PTH and vitamin D level. If the intact PTH is above the target for the stage of CKD and vitamin D level is less than 30, vitamin D should be repleted. If the PTH is above target for the stage of CKD and vitamin D level is greater than 30, then therapy with an activated form of vitamin D, in the form of calcitriol, doxorcalciferol, or paracalcitol may be indicated. How does one replete vitamin D? Well, this is a suggested schedule from K-DOQI. And that is for the most severe forms of vitamin D deficiency, a 25 hydroxy D level less than 5. One would give 50,000 units of ergo for 12 weeks and then once a month for a total of 6 months. If it's 5 to 15, you give weekly doses for 4 doses and then 50,000 units monthly for a total, again, of 6 months. And then if the levels between 16 and 30, then give 6 months of monthly ergocalciferol. Now, for those patients who don't respond to either activated vitamin D or cinacalcet, one may need to consider parathyroidectomy. And the indications for parathyroidectomy include severe complications of renal osteodystrophy such as skeletal pain and myopathy. But these patients may also have severe pruritus, and then other things have also been noted in these patients, including cramping, depression, and hypertension. So we reserve parathyroidectomy for the patients who have the more severe forms of hyperparathyroidism that's not responding to the medications. So this is from the New England Journal paper that was published in 2004, showing the efficacy of cinacalcet in reducing the PTH. So the median PTH in this group of patients was about 684, and you can see that compared to placebo, the patients who were treated with cinacalcet had a nice reduction in their PTH level over that time period. So, to summarize, use the K-DOQI CKD staging plan to guide your treatment. The MDRD equation is the preferred method for estimating GFR in patients with CKD. However, it should be used with caution in patients with more normal or lower serum creatinines. Blockade of the renin-angiotensin system is important for patients with a range of chronic kidney diseases, diabetic nephropathy, proteinuric kidney diseases not related to diabetes, hypertensive nephrosclerosis in African Americans particularly, and in hypertensive patients with microalbuminuria. ESAs are an important therapeutic tool in the treatment of anemia. However, overshooting hemoglobin targets is detrimental. Patients with CKD are at high risk for development of hyperkalemia with RAS blockade. This hyperkalemia can often be traced to medications, notably NSAIDs and Bactrim. CKD-MBD is a common complication of kidney disease, and its treatment often requires dietary phosphate restriction, phosphate binders, vitamin D analogs, and/or cinacalcet. So the first question, a 70-year-old woman develops dysuria from a UTI with E. coli. She's prescribed trimethoprim sulfa. Her creatinine, which had been 1, increases to 1.3. She has no rash, eosinophilia, or eosinophiliuria. Her dysuria resolves with treatment. She has no other symptoms. After completing the course of Bactrim, her creatinine is rechecked and it's back down to 1. So which of the following most likely explains the increase in serum creatinine? Is it acute kidney injury due to volume depletion? Is it acute kidney injury due to interstitial nephritis? Is it that the creatinine has risen with no change in GFR due to the effects of trimethoprim on creatinine secretion? Or is it acute kidney injury due to pyelonephritis? And the point I want to make from this question is that there was nothing in her history that suggested volume depletion. She had nothing to suggest interstitial nephritis. Her symptoms are limited to the lower urinary tract, no evidence of pyelo. So the best answer is C, that there may be changes in creatinine secretion with treatment with trimethoprim sulfa without a real change in the glomerular filtration rate. The second question, a 60-year-old man with CKD stage 4 from diabetic nephropathy complains of fatigue, limiting his ability to play golf. He's anemic with a hemoglobin of 11, and a hematocrit of 33%. His iron saturation is 9%. So which of the following would be appropriate next steps in the patient's management? And given erythropoietin sub-Q weekly to achieve a hemoglobin of 13. Give darbepoetin monthly to achieve a hemoglobin of 13. Give IV iron. Check for occult GI bleeding, or both C and D. Well, choices A and B are both incorrect because that target hemoglobin is too high. The patient is iron deficient, so it would be appropriate to check for occult GI bleeding and to administer IV iron. Remember, these patients often have a block on absorption of iron and will respond quite nicely to repletion with intravenous iron.